discussion.
Maybe start, ma'am, now?
Yeah.
Yes.
Good afternoon, everyone. Today we'll be discussing a case of alveolar cleft with oronasal fistula. A 9-year-old girl presented with a defect in the alveolus and an oronasal fistula. There was an associated cleft lip and palate, which were repaired surgically at the age of 1 year and 6 years respectively. Also, there was an ocular abnormality associated, which was repaired through implantation of an prosthetic eye. The child was first born female and from non-consanguineous marriage. There was history of nasal regurgitation present, no history of ear discharge, and no significant antenatal history. Also, there is no family history of any congenital abnormalities, and immunization has been completed till date. Upon general examination, the patient is active oriented to time, place, and person. The vitals were stable, no pallor present, weight was 16 kg, and in systemic examination, all within normal limits. Upon local examination, extraoral findings, there were residual scarring and lip asymmetry present, and with slight malalignment of the vermilion border. Lip contracture can also be seen in the upper lip, and asymmetry of the nostril can also be seen with tip deviated to the right side. On intraoral findings, alveolar cleft and oronasal communication can be seen. There's a visible cleft in the gap on the second quadrant. There's malalignment of the central incisor and the deciduous canine, and the soft tissue condition around the teeth has also been mentioned. Can be seen. There's some gingival inflammation and a little bit of recession present at the permanent lateral incisor. Central incisor. Upon radiographic examination, visible radiolucent gap in the second quadrant can be seen, which is indicating a cleft between the alveolus and the nasal cavity. There is missing permanent lateral incisor. Also, the deciduous canine and central incisors are malaligned, and there's a very possible communication with the oral and nasal cavity just by looking at the radiograph. The diagnosis on which we arrive is a left unilateral alveolar cleft with missing lateral incisor and oronasal fistula. Should I go ahead with the treatment plan?
Yes.
So for the treatment plan of this case, first of all, we'll go for pre-surgical orthodontics. The objective of this pre-surgical orthodontic is to align and the level the teeth for surgical outcome. First of all, there is expansion of the maxillary arch, then alignment of the teeth to ensure proper eruption of permanent canines, and then orthodontic movement. Second, once we know that the canine root is either 1/2 to 2/3 form, we can go ahead with the surgical grafting. In this case, we will go for secondary alveolar bone grafting. The graft will be taken from the alveolar crest, and following the during the surgical intervention, we'll also close the oronasal fistula. Post the alveolar grafting part, we will wait for a good 3 to 6 months, and post surgical orthodontic management will be done for the patient. Later on, if a need for lip revision or rhinoplasty arises, we can go ahead with it. And for more definitive orthodontic correction, we can go for orthognathic surgery, and speech and functional rehabilitation has to be seen. Thank you.
Presentation is over.
Yes, ma'am.
Dr. Umar?
Madam, Dr. Adil is the panelist.
Yes. No. Dr. Umar Farooq joined. So,
Yes.
Umar Farooq, Baba.
Yeah.
Good
I'm here.
afternoon.
Good afternoon.
Yeah. You and Tahar can conduct the session.
Sure.
The
I'm here only.
panelists are invited to ask the discussion. Okay.
So first we'll start with Dr. Adil. If he can
Adil,
start.
sir.
Adil sir, if you can start the the discussion for this, and you can start asking questions about the case.
Okay. So you mentioned that you will get the bone from the iliac crest. So what will be the steps in the procedure, and what is the advantage of using that site for the grafting?
We'll go for we can go for a trapdoor technique in this. One, the first we'll go with the step. First of all, the surgical site can be marked, and the incision is using a pen. We can mark the incision. Then we can infiltrate the area using a tumescent solution, which is generally we can use it or we cannot use it. Gives a good hemorrhage to the area. First of all, the skin, and once we are giving the incision, we have to make sure that we retract the skin over that region a bit medially so that the incision does not fall over the bone and there are less chances of descent. Then once we go through the skin and subcutaneous fat, we'll reach the periosteum of the bone. We have to be careful while dissecting the periosteum and the muscles around it so that post surgery the patient does not face any problems such as gait disturbances. And then once the cortical bone has to be osteomatized from three sides. On the medial aspect, we do not remove its connection with the periosteum. We can open it like this. Then the calcaneous portion of the bone can be taken either with the help of a scoop. Then again the cortical portion is placed back and it's sutured. The muscle around it sutured carefully, and then the skin closure is done.
So you're talking about a lateral trapdoor, is it?
Yes, sir.
Okay. And in this age group, will you have cortical bone covering the iliac crest, or what will you encounter?
So yes, there will be cortical bone covering the iliac crest.
Usually we encounter cartilage only, and we're able to cut through the blade and do a kind of a clamshell, open up the cancellous bone and get it, harvest it and cut it and put it into place. Okay. What about the recipient site? What kind of incision you will take there? What are the flaps you will create? And what are the things which will help you ensure the success of the bone graft take up
So
at the recipient site?
So at the recipient site, so we can go for a gingiva perioplasty. We can include the gingiva from the adjacent. We can take a clavicular incision around the teeth which are involved, and we can make sure the alveolar defect is completely exposed. Then we can go ahead with the repair of the nasal fistula. Then we can place our graft in the area, and then we can take us one of the modifications. We can take a oblique advancement of the flap from the non-cleft side and cover that area.
So you have to mention important steps like the periosteal release, advancement across, watertight closure on the nasal aspect, labial aspect, closing to the palatal, things like that. Okay.
Okay.
Apart from that, what is there anything additional you can use with the bone graft which will help to improve the?
So we can add recombinant factors in the bone graft to increase its osteoconductive and osteoinductive potential. We have RHBMP2, which has shown some promising results in these cases. So we can add
Is
that.
RHBMP commonly used or anything else? What is more commonly used in day-to-day alveolar bone grafting? Or the platelet concentrates
Yes,
and
sir.
things like that are-
Yes, sir. So we can add PRF to the mixture. We can add IPRF and LPRF. That can also be helpful.
So what are the different timings that these procedures have been taken up historically? And what are the best timings that we should take up this procedure and the advantages and disadvantages of each?
Okay, so the alveolar bone grafting has been divided. We can divide it according to the chronological age or according to the dental age. So if you're talking about the chronological age, there have been a primary alveolar bone grafting, which is done by the age of 2 years. Then we have secondary alveolar bone grafting. Further, it is further classified into early and secondary alveolar bone grafting. The early alveolar bone grafting is done around 2 to 5 years of age, and from 6 to 12 years of age, that is your secondary alveolar bone grafting. Anything which is done beyond 13 years, so 12 years, is your tertiary alveolar bone grafting. This is according to the chronological age. Then if we go by the dental age, we have primary alveolar bone grafting, which is done in deciduous dentition. Then secondary alveolar bone grafting, that is done in mixed dentition, and tertiary alveolar bone grafting, that is done in permanent dentition. So in any of the patient which we face, we do not find that the chronological and the dental age, they coincide with each other. So we come up with a plan. If you're talking about this primary alveolar bone grafting, earlier we used to repair the lip along with the alveolus if with the need felt, and in this case generally the rib or the costal cartilage has been used. But because of the extensive time it took and the effect it had on the maxillary growth, this process has not been advocated that much anymore. The ideal treatment, or the most approached, most often used treatment which we go, or the time which we go, is secondary alveolar bone graft. That is the mixed dentition phase around 9 to 11 years of age. Uh, it helps us with the timing of the permanent canine eruption also. If we talk about the early primary secondary alveolar bone grafting, the concept behind it was to facilitate the eruption of lateral incisor, permanent lateral incisor. So the bone grafting done before the eruption of permanent lateral incisor helps to facilitate the eruption, and it also have shown that the root resorption have been very less. And in cases where we have to go for bone grafting after the deciduous period or the canine has not been erupted, then that is termed as tertiary bone grafting.
Okay. What are the benefits which are given to the patient for in the bone grafting procedure? In the future, also, what benefits will they be getting? What all procedures will be have better outcomes? Can you discuss over a period of time? Apart from the dental tooth eruption, what are the other procedures that can benefit from doing a good alveolar bone graft?
So apart from the tooth eruption, the patient will have a well-aligned dental arch. The maxilla, the development of maxilla will be proper. Also, there will be a support for the nasal structure to rest on, so that and,
Yeah, so there'll be a continuity of the maxillary arch,
yes,
and the nasal base or the alar base will get some support. And in case of an orthognathic surgery, the maxilla will become one piece. So
yes,
that's
sir.
the benefits that come to the patient, apart from the dental uses. And the oronasal fistula will get corrected, and there'll be no persistent regurgitation of liquids.
Yes, sir. Yes.
Um, what all is the common donor site morbidity, and how can you prevent that in the iliac crest? What care you take during the incision? What structures you have to stay away from? What are the important structures around? And what is a common alternative today to the iliac crest when you want to harvest for the alveolar bone graft?
Okay. Sir, I'm sorry, sir. Can you repeat your question, please?
The question is, iliac crest has got some donor site morbidity. What is that? What are those common morbidities? What are the structures which are close by, and how will you prevent them or avoid them during this surgery? And can you name any of the other alternatives that can be used to harvest the bone graft for the surgery?
Okay. So first of all, the important structures which are nearby the incision site. There are nerves which we have to be careful about, like ilio-hypogastric nerve. Then you have ilio-inguinal nerve, and then lateral femoral cutaneous nerve. So when we are marking the incision site, we have to be careful. Second, as I mentioned before, that we have to retract the skin a bit medially. laterally, so that the incision does not fall onto the bony prominence and there less chance of dehiscence. And I think so these are the two main points which you have to be careful while going for the iliac crest. Second, once you are taking the incision, we do not have to approach the anterior crest. We have to stay behind it, and if you're going for the posterior crest, then we have to stay ahead. We do not enter that area. And sir, apart from alveolar, iliac crest, we can go for different sites. We can take either from mandibular ramus, parasymphysis or symphysis region, but the amount is not that much. We can also take rib grafts, or we can take graft from tibia.
So your incision should be 1.5 to 2 centimeters behind the anterior superior iliac spine.
Yes, sir.
That is a specific kind of this thing. So you don't move around that area where the nerves are crossing from medial to lateral. To stay within the safe confines, right? Okay, I'm good.
Can Dr. Charanya join Dr. Adil in the discussion?
Yeah.
Dr. Charanya.
Yeah.
Or,
Can I go ahead?
yeah, please. Hi.
Yeah, please.
Dr. Adil has covered most of it. I just have a few questions to add on to that. What are your comments on choosing a medial versus a lateral trapdoor for your donor harvest?
Ma'am, I would prefer a medial trapdoor harvest.
Arya, you should be very loud. Be loud.
Okay,
Your
sorry,
voice is very low. Okay.
Okay, sorry, ma'am. I'll take care. Is it fine now, ma'am? Am I doing
Yeah.
It's
better?
all right. You have to be a bit louder.
Okay.
Louder.
Just a bit louder.
Okay, sir.
It's fine now.
Okay. Ma'am, I'd choose a medial trapdoor method because that would give a better outcome to the surgery.
And how?
Ma'am, while we're doing the osteotomy of the site, it's much easier to approach the lateral than going to the medial.
Okay. And has it got any advantages in skinny people? In skinny people, has it got any real advantages?
Not that something I can think of, ma'am, right now.
The team 2 can answer. Team
Hello?
2 pages also can answer if the
Ma'am, are we
team was
audible?
unable to.
Ma'am, are we audible?
Yeah.
Yeah. Be loud.
Is it
Yeah. If you want, you can answer.
So-
ma'am, I think we will go for a medial approach rather than a lateral approach. Medial approach, why? Because it has better access to the cancellous bone or the spongy bone, which we say, and the closeness to the surrounding vessels, that is the lateral femoral nerves, which is present. So it would get retracted like the safe distances which are present. So that is why medial approach is better than a lateral approach. And in lateral approach, maybe we'll encounter over the cortical bone rather than a cancellous bone to harvest. So that is why medial approach would be a better than a lateral approach.
Okay. Can I
Dr.
go ahead?
Charanya,
Can I go ahead with the next question?
you
Yes.
are happy with the answer?
Yeah, it is reasonable. And my second part of the question was, does it have any real advantage in a skinny person? See, if you go ahead with a medial trapdoor versus a lateral trapdoor, if there is, bony discontinuity or any defect, it won't be felt on people with less flesh. If you go ahead in a medial trapdoor, the trapdoor will not be felt through the skin. So a lot of people prefer to go ahead with that for cosmetic reasons as well.
And that's the explanation for that. Then you can continue with Maria for the next.
Yeah.
Yes, ma'am.
Dr. Altaf sir would like to ask any questions.
Not now, madam. I'll when I do my slides, I will do that. As of
Okay.
now, I think Charnya and
So,
Yes, Dr. Charanya can continue, or Dr. Adil can also join.
I
They
have
can-
another question as well. Can I
Yeah.
go ahead?
Sure.
So my next question for the doctor is, you did mention in your presentation that you would go ahead with the expansion of the alveolar arches. So as a surgeon, how will you decide how much of expansion is sufficient?
And that
Dr. Maria.
Yes, ma'am. Yes, sir. Ma'am, that's for the orthodontist to decide.
So you will accept what your orthodontist gives you?
Still, any idea how you can go about it? Ma'am asked that.
You
There should be something in your mind
you
also.
did mention about some amount of leveling and alignment.
Yes.
So would you look at something in your occlusion before you decide this is sufficient or this is insufficient?
he too can answer.
Yeah.
Ma'am, we'll check the amount of crossbite, whether there is any crossbite.
The alignment of the arches, which we have achieved, since first the arch would be collapsed and narrow.
Absolutely. So if you can correct the crossbite before your bone grafting, it's going to give you a better outcome, isn't it?
So out here, the key to understand is many orthodontists think of expansion as molar in the molar region. What happens commonly in our pre-ABG time is about the anterior crossbite, especially on the cleft side. If you've got a collapsed arch and it's inside, you need to have pre-ABG expansion. And once the crossbite is corrected in the occlusion, you should go ahead. In this case, though, it doesn't seem like the arches are too collapsed and may not require, not required for expansion in this case, because there's a good gap and there's no collapse of the arches. It looks well formed. All right.
Fine. Dr. Charanya?
Yeah. So my next and the last question for the doctor is, you
Fine.
did mention about moving your flaps, advancing your flaps to close the defect. Which flap, the medial element or the lateral element, would you move to close it?
And the lateral element.
Good. And why is that?
I think it will give me more advancement and mobility over the defect.
And what would you do to mobilize your flaps?
Ma'am, I'll do an periosteal scoring. Make sure it's enough advanced enough so that while I'm closing it, there's no tension and I can have a watertight closure.
Okay. And can you be louder with your second part of the answer?
Now I said I'll make sure the periosteal scoring is enough so that the flap can advance without any tension and we can go ahead with a watertight closure.
If your periosteal scoring is not going to be sufficient, what would you do to the flap?
Ma'am, on the distal side, we can give some releasing incision so that advance it furthermore.
And at what level would you do that?
Above the mucogingival junction, around 2 to 3 above it.
About where?
Be
Be a bit
loud,
louder, Maria. Beta, be a bit louder.
So
loud,
is it
Maria.
alright if I wear headphones? I can speak over it.
No issues, you can. Be a little bit louder so that ma'am hears clearly. It's fine.
Am I audible now, ma'am? Am I
Yeah,
audible?
yeah,
Yes, yeah, please.
clearly.
Yeah.
So, ma'am, we can give the releasing incision at the end if on the lateral aspect, the distal end, we can give the releasing incision over there near the mucogingival junction so that the entire thing can be advanced easily.
Yeah, do you have a landmark,
Exactly at
a
what
dental
level?
landmark where you will make your cut?
I don't know.
Next team
Next
can
team.
Charulata and
No, sir, even we do not.
So you usually go as distal as possible, and you can have a reference of your first permanent molar as a region from where you can make your bad cut. Okay,
Yes, ma'am.
and this should be in front of your duct so that you don't
yeah,
accidentally damage
Yeah.
the duct. Okay,
very well, sir.
I'm done with it. My question, sir.
Okay, I can ask one more question.
Sure.
Yeah.
There is a difficulty of closing the nasal layer, especially where the cleft becomes narrower and distally. You are not able to take those stitches right at the back. Sometimes there's a persistent leak. Okay. You are not able to pass your suture through or turn it around and close those flaps, which are very deep inside. Is there anything that you will harvest apart from the cancellous bone when you go for your anterior iliac crest, which can help to block that gap which you're unable to suture primarily? Have you read any articles which have come out in relation to this?
So
Do you
I've
understand the
read
question?
about vascularized and non-vascularized iliac crest graft, but I don't think so that could be of any advantage over here.
Correct.
Any tissue, sir? Ask any tissue. I think it is the same. Am I right, Adil, Dr. Adil?
No, so actually there is this carpus fascia, which is one of the layers when you are approaching the anterior iliac crest, and a small rectangular part can be removed, and that area where you're not able to reach can be sutured transpalatally to kind of block that area and not allow any communication from the deepest part where you're suturing. That's even the Changan team uses that in doing these
I've
closures.
heard from them all the same. Yeah, you're right.
Carpus fascia is the answer. I'm good.
Sir, just one last question. Yeah, in relation to the question that Dr. Adil mentioned, is there anything that you could use as a synthetic alternate to that?
Ma'am, we can place a membrane over there, which can help us. We can use a collagen.
What kind of membrane is that?
We can
would
use
you
a
choose?
collagen membrane.
Any other options?
What people are doing nowadays, ma'am, asked the same. It came to my mind also, the same time.
Are there any other synthetic material that has been described in the literature of late?
We can use
Team 2?
Charulata and team.
PR, P and PRF can be used, but synthetic.
No, that is separate thing. That is a separate thing.
Then membranes, synthetic membranes, Teflon membranes,
Polyteflon. Right.
PTFE, polytetrafluoroethylene. That's
The camera.
Of late, what some people are using. Madam asked same. Anyways, madam can go ahead because there is no answer from you.
So the answer is they are also using what you call fish membrane, which has been used in the market in the United States. It's FDA approved, and it has also been reported in the literature recently. So that's the answer to the question.
Oh, the time is over for the
Yeah.
discussion also. Yeah, think we can go ahead with the second team presentation. I think Adil has shared this case. I think Adil, can you show the para pen
Result.
stop photos of
Yeah,
the
can you
case?
just give me permission to share screen? Or can I do
Yeah,
it
you
directly?
can share. Maya,
yes, ma'am.
she already stopped sharing. You can do
Yes,
that.
ma'am.
Just briefly describe how you.
Is my presentation visible?
Fine, fine, it's fine.
So this was the girl. She came. She had a lip done, and when she was 1 year old or something at a different center, and she
Yeah.
came. Palate was not operated at around the age of 6. So first we did a palate, and we also sent her for some orbital processes. And a little bit after this X-ray was taken up for ABG, and this was the recipient and the donor side. In the recipient side, in the first image on the top left, is the nasal flaps, which are visible, and then the nasal flaps have been closed to repair the nasal floor. And like I said, that more than bone, when you open up at this age for the ABG, you will see cancellous bone. So you can actually, you don't need to do a trap door or anything. You can just cut it with a blade and with an osteotome or a gauge, open it up and harvest the bone. You can close the cartilage back with sutures. This is the cancellous bone which we ground down finely, and we placed it into that alveolar this thing after closing the nasal floor. And the primary closure with the flap, which is having a releasing incision in the middle of the first permanent molar. And in the medial side, there are no releasing incisions. And afterwards, 6 months later of the closure photo, this is about 1 year later, the canine, the permanent canine has now erupted through the bone graft. It is a little bit palatal now, and she may need some expansion, or she'll directly go for orthodontic fixed braces. So this is what we had started out with. This is what she was after 3-4 years. And she's now doing her fixed braces. There were also 1 or 2 different scenarios about the bone graft. Should I go ahead and show them right now quickly?
Yes, sir. Yes, sir. Please.
Actually, after next case discussion, we'll give time for each panelist. At that time, you show the other cases.
Okay, this is this case, pre and post, and the bone is looking well consolidated, and some trabecular pattern has also come up, and the canine, permanent canine, has erupted down. Still, the root formation is not complete, but almost there. That's all for this case.
Thank you. Uber will allow
Yeah.
the second team also to present.
Yeah, sure,
The
sure.
equal time will.
Let them also come forward now.
Tahir, you just invite them.
So Charlotte, Saldana, and Nehal Ambawat are the next PGs. They are
Present in
from
the
MGM Hospital, Navi Mumbai. So, Dr. Charlotte and Dr. Nehal, please start your presentation.
invite the panelists.
And the panelist for this session is Professor Umar. He is the Fellowship Director of Orthopneumatic Surgery at AOMSI and also a consultant at King's Al Shifa Hospital. So, please start. Yeah.
You can make it full screen.
Can I do that?
Just stop sharing here. Sir, is our presentation visible?
Not yet. Now it is okay. It's fine.
So this is a case of a 23-year-old male who reported with a chief complaint of anesthetic appearance of his face. He has a past dental history. He underwent orthodontic treatment for alignment of his teeth for 6 months. Past medical history, past surgical history of 4 surgeries for cleft lip, cleft palate, VPI correction, and SABG. Habit history is not present. There is an aesthetic and functional concern, which is a reason for treatment. House classification, the patient is philosophical, and on socio-psychological evaluation, he is stable. General examination, patient was moderately built and well nourished. Body type was mesomorphic. On TMJ examination, there was no clicking or tenderness or deviation present. Mouth opening was adequate. The ethics frontal analysis, facial form was hyperleptoprosopic. The face was divided into thirds. The upper third and the middle third were 30 mm and 31 mm, and lower third was 43 mm. The bigonial to bizygomatic width ratio, which is ideally 30%, was actually 1.07:1 in this case. Incisal show at rest, upper incisal show was 0 mm, lower incisal show was 2 mm, and interlabial gap was 3 mm. Transverse facial dimensions, the face was divided into nearly equal fifths. The alar base width was slightly greater than the intercanthal distance. The gonial angles fall outside the line passing through the outer canthus on both sides, and the commissural width of the mouth was nearly equal to the interiridial distance. On profile view analysis, the profile was concave with an anterior divergence. Bilateral paranasal hollowing was present. Positive lip step was present. The mentolabial sulcus was obtuse, and there was an acute nasolabial angle with a prognathic mandible. So the frontonasal angle was 132°, nasolabial angle was 90°, and the labiomental angle was 113°. The upper third, no gross deformity was present. The mid-face to lower face ratio was 0.72. On examination of the middle third, there was bilateral paranasal hollowing that was present. The columella was deviated to the left. Left alar base flaring could be seen. Columella to lobule ratio was 1.44. The nasal base width was 60 mm and the nasal tip width was 26 mm. The lower third lips, the scar of previous surgery was present on the left side upper lip and philtrum region. There was notching of the left side upper lip. Prognathic mandible was present with increased vermilion exposure of the lower lip. Upper lip length was 15 mm and lower lip length was 30 mm. No occlusal cant was present when we drew a parallel line joining the pupils. Intraoral examination, this is the post-orthodontic pre-surgical occlusion. Bilaterally, a posterior crossbite was present. Even the canines were in crossbite posteriorly, and there was a reverse overjet of 4 mm.
Coming to his radiographic analysis, this is the OPG of the this is a OPG of the patient which is under currently the OPG is underexposed, and we can see that the bilateral condyles are normal, like there is no evidence of any condylar hyperplasia, which can be evidently seen on the OPG. We see a radio opaque material or radio opaque material which is present between the 2-1 and 2-3. Since the patient had history of SABG, speaking of which that it could be a bone graft which would be present in that region. Congenitally, there are missing lateral incisors. This is a lateral cephalogram of the patient. Coming to his cephalometric analysis, so the SNA angle is 73.4 degree and the normal is 82. So the inference of the Steele's analysis is that there is a retrognathic maxilla present, and the mandible is close to normal position in the Steele's analysis, that there can be a mild mandibular intrusion or normal positioning, and highly negative A and B, which suggests a class 3 malocclusion where mandible is significantly ahead of the maxilla. Coming to its width analysis, there's a negative value of minus 5.3. So this confirms the skeletal class 3 malocclusion, indicating the maxillary intrusion and mandibular prognathism. Coming to its Tweed analysis, in Tweed analysis, that is Tweed's analysis is also the treatment triangle, which we call it. So it is slightly decreased FMA angle that indicates a horizontal growth pattern and indicating a relatively low mandibular plane angle, a slightly increase in the IM PA angle, that is 91 to 91.2 degree, which suggests mildly proclined lower incisors. Then coming to his Downs analysis, that is there is a strongly negative angle of convexity which is present, suggestive of class 3 skeletal pattern, and severely positive AB plane value which suggestive of class 3 discrepancy, and minimal occlusal cant which is seen radiographically but not clinically, and lower incisors are upright and mildly retruded in relation to the upper incisors. This is the Cox analysis. So inference suggestive of severe class 3 malocclusion, short maxilla, and lower facial height. The lower facial height, coming to the lower facial, that there is mid-face deficiency and lower incisors are retroclined. The upper incisors are slightly proclined, which suggestive of maxillary retrusion, and severely negative width appraisal angle, which confirms the skeletal discrepancy. So this was the pre-operative occlusion which was present, and this is the best possible occlusion after a surgical management. Coming to summary of all my analysis. So the skeletal analysis, the SN angle is decreased, which suggestive of maxillary retrusion. SNB increased, which suggestive of mandibular prognathism. The ANB value, which was negative, which confirms the skeletal class 3 relationship. The width appraisal, which was negative, which is supporting of the maxillary deficiency. The Golian angle, which is increased, which is suggestive of increased mandibular growth. Coming to its facial profile, which was concave with the anterior divergence, confirms the skeletal discrepancy which is present. Vertical analysis, the FMA angle, which indicates the maxillary deficiency. Mandibular plane angle, which is increased, so it is suggestive of a high angle case. His facial proportions, so his facial proportions were nearly equal. So the upper third to lower third, that the ratio comes to 5:6. And in this patient, it is not that increased to a severe extent. It is increased since the lower facial height, it is 43 mm. Coming to his dental analysis, the overjet is -4 mm, and sorry for the mistake over there, which confirms the anterior crossbite. Canine relation is end-on bilaterally. posterior crossbite, which is present bilaterally. The upper incisor proclination, which says about the dental compensation because the mandible is prognathing, and the lower incisor retroclination, which is decreased, that is because of the dental adaptation to the skeletal clasping. The soft tissue analysis, the nasolabial angle is 90°, suggestive of maxillary retrusion. Labiomental angle 113, which indicates mandibular prominence. The frontonasal angle 132°, which and the increased lower lip vermilion exposure supports soft tissue imbalance. The bilateral paranasal hollowing, indicative of the maxillary deficiency, and a positive lip step, which suggestive of the disharmony in the lip position. So depending on all the cephalometric and the clinical diagnosis, our diagnosis is type 1, mild cleft maxillary hypoplasia. We have also included a slide on the treatment plan. Coming to the treatment considerations of this.
Wait for a moment. Umar sir, if you want them to stop here or you want to ask the questions what they have presented.
Yeah, I will start my question.
Okay, sir. Please, sir.
Yes. What causes cleft maxilla after lateral surgery?
So could you please repeat? We could not hear you.
What is the etiological factors for hypoplasia in case of a cleft palate case?
Etiological factors in case of a cleft.
Yeah, cleft hypoplasia.
Cleft hypoplasia.
The maxilla is hypoplastic, you know. After
So the patient has undergone previous palatal surgeries, due to which there can be a scarring of the palate that is present, so which affects the growth of the maxilla. So it can lead to cleft maxillary hypoplasia in such cases. The transverse as well, because there is deposition of there is fibrosis on the sutural level. So that is why the expansion and the forward growth of the maxilla can be affected. So that is why they can. It is one of the causes of cleft maxillary hypoplasia.
Along with that, also there is muscle dysfunction because there is cleft, which is unilateral cleft lip, which is present in this patient. Also, the intrinsic growth factors we take into consideration for the maxilla development, that the maxilla develops in a downward and a forward direction in the initial phase. But when there is a cleft which is present, this the movement is restricted, the overall growth at that sutural levels is restricted. And also considering the various genetic and the environmental factors which will add on for the restriction of the growth.
Right. Then what are the effects of cleft maxillary hypoplasia on facial appearance?
So there is a retruded maxilla. Basically, the mid face appears to be inside. So there's a concave profile. The patient has some amount of difficulty in phonation and speech, as well as eating difficulties could be present because there appears to be drooling of saliva because the closure is not obtained. There is a class 3 occlusion that is present.
And but there would be bilateral paranasal hollowing, which would be present in such in these patients.
What are the important functions that is affected by this?
So the important function which would be affected because of the cleft maxillary hypoplasia, first would be the articulation and phonation in these patients, because there was a history of cleft lip and then cleft palate also. Whether we don't know whether the VPI's surgery was being done or not for this patient, and also because of the compensation which is present, as there is a class 3 occlusion and the maxilla is retruded. So there is a compensation which takes place. So the articulation, because of this, the sibilant sounds, the linguoalveolar sounds are affected in these cases.
Yes, the main function affected is the speech, articulation.
Yes.
Then what are the investigations for this analyze
So
and
for,
treatment? What are the
so for
important
BPI, you are asking?
in a cleft maxilla case? What are the important investigations? If you want to do the surgery, what are the important investigations you go do?
So cephalometric analysis.
Yes.
Airway analysis, because if we find that depending upon how much amount of advancement we have to do. So if we are planning for a setback also, so we need to keep in mind that the airway is not compromised in these patients. Along with that, as I mentioned about the VPI also. So for VPI also we have the
Perceptual speech assessment has to be done.
Perceptual speech assessment,
video
nasal
fluoroscopy,
nasal endoscopy, video fluoroscopy for assessing
nasometry.
the speech.
What all X-rays? What X-rays you take? Which one?
PSF, lateral self,
lateral self,
OPG.
OPG, and
Then you have to take the models also. I should not mention models.
Impressions, yes.
impression.
Then so what about the CT scans?
CT scan.
Virtually.
If you want to,
If you want to
virtual surgical
virtual
planning
surgical
for
the
maxillary
osteotomy
advancement or
cuts or
planning the
something.
osteotomy cuts, then a CT would be helpful.
Especially for VSP, it is very much needed.
Yeah, VSP.
For
If you are
virtual
planning a virtual surgical planning for this case, then a CT would
To
be
decide
helpful.
the osteotomy cut positions, if at all we are if the patient will undergo an orthognathic surgery.
Yes.
What are the investigations you go for a speech analysis?
So
Speech analysis.
What are the investigations?
So video fluoroscopy or the perceptual speech assessment.
One more.
Audiometry.
One more important.
Nasometry also can be done.
Other team can answer if you are not.
Yeah.
Nasoendoscopy can be done.
Nasoendoscopy and men. What you will get in nasoendoscopy? What are
That the soft velum it touches. There is minimum gap between the soft palate and the pharyngeal walls.
Yeah. It will exactly point where is the gap. It is a midline or in the lateral aspect. Accordingly, you can modify the surgery.
It's a lateral aspect. On lateral aspect, we can.
What are the treatment options say for a cleft maxilla?
The treatment of
So depending on the age, whether the patient has completed the growth phase or no. Now this patient is 23 years old. So he has completed the growth phase. So we'll see whether there is any past history of previous surgery, the number of palatal surgeries. So this patient has a history of cleft lip surgery, cleft palate surgery, VPI correction and SABG. Other than that, the age is 23 years. So he has completed the growth phase. However, in this case, we do not know the VPI closure ratio, whether it is severe, moderate, and mild. But we were told that the patient had a mild VPI prior to the procedure. So since the VPI is mild, we can go in for an orthognathic surgery. And because the maxilla is retruded, and according to the analysis, there is a prognathic mandible. So we could also go, along with a Leafort 1 osteotomy and advancement, we can also go for a mandibular setback surgery.
But that depends upon how much advancement are we planning. Because in greater advancement cases, the minimum which should be advanced is around 8 mm, and it can go till 10 mm if there is a need for that procedure. But for such a great advancement,
Distraction is
yeah,
preferable.
distraction is
will be
preferable, and then we have to consider a 2-jaw surgery instead of a 1-jaw surgery.
Also, the clinical examination that we have done, the pictures are post-orthodontic pre-surgical clinical pictures, whereas the cephalometric analysis is being done on pre-orthodontic radiographs. So we should have had the post-orthodontic radiographs. So based on that, we could do the correct cephalometric analysis. However, we did not have access to that. So based on whatever analysis we have done on the pre-orthodontic, because after the orthodontic treatment also there will be some amount of compensation, because on the width appraisal the reverse overjet 5.3 m. However, the clinical picture there is a reverse overjet of 4 m. So depending on that also we can decide whether mandibular setback surgery needs to be done or not.
And in considering the patient's lower facial height, which is increased in this case. So depending on the maxilla, how much has to be advanced, whether there has to be just an advancement or a rotation has to be planned or not in this case, is also to be taken consideration while doing the treatment plan.
The rotation will be counterclockwise, because clockwise, if at all we are, if the patient has to undergo a rotation, it would be counterclockwise, because the clockwise rotation would further increase the lower facial height.
So generally speaking, the two treatment options are our conventional orthodontic surgery and distraction. Then what are the indications for distractions?
So if the VPI is severe, we can go in for an anterior maxillary distraction. Because if we attempt to do a osteotomy, it can further worsen the VPI. So that is
also when we need advancements for more than 10 mm. So in that cases, a distraction can be considered because
total maxillary
distraction.
Yeah, there are two distractions.
There are two distractions: total maxillary distraction or AMD, that is anterior maxillary distraction.
Now, what is the indication for AMD and the distraction?
AMD,
in cases of severe VPI, AMD will be preferable. So the osteotomy cut is given between the first and the second molar. So without touching the soft palate and the velum, only anterior distraction is done. And in total maxillary distraction, the whole, along with Leafort one, it has to be, distraction has to be performed.
Suppose if the AMD is not sufficient, then what option is there? Suppose there is the reverse overjet is more than some 10 millimeter. In such case, what do you do?
Correct the VPI first and
correct the VPI
and
pause
then
for a year, whether there is the VPI improved or not, or is it worsening. Depending upon that, the treatment plan would be executed.
In certain cases, you have to do anterior maxillary distraction. After that, you can go a mandibular setback also. So the speech is not affected. Then what are the different distractors?
There can be a internal distractor or a external distractor. So the external distractor uses the support of the cranial base, and the internal distractor is alveolar bone distractor, which is placed intraorally. So
what is the advantage of rigid external distractor over the internal distractor?
So please could you repeat?
What is the advantage of external rigid distractor? RED.
External rigid distractor. So external, it
Over
can
internal
be,
yeah.
it can be removed.
It's mainly aesthetics if it is an external distractor. Internal distractor. Aesthetics will not be affected.
Yes, the psychological
Oh.
impact of the patient also of going out, that
That is a
if of
that is a disadvantage. What is the advantage of RED? That is what I'm asking. You can
Team
change.
1 can answer.
Pardon, sir?
Team 1 can answer if they cannot. You can say yes or
Maria?
no so that we can move
Maria?
ahead.
Yes,
Maria,
move ahead.
Rafsia.
So we don't know.
Okay, beta.
Okay.
Sir, you can then
Okay.
go ahead.
The advantage of external distractor is that you can
it
change
can
the
be removed
change the
easily.
vector,
I can say.
but the internal distractor already fixed. No, if
Yes.
you want to change, it is difficult. You have to go again for anesthesia and all. It is difficult, but it can be manipulated. External regional distractor. That is the main advantage of the external region distractor. Then what about the stability? The stability with the distraction and also with the conventional orthognathic surgery, which has got more stability.
You got the question? Nihal, you got the question what sir is asking?
No, sir.
The aim of the surgery is aesthetics, then stability, then better function. So considering the stability, if you do a distraction osteogenesis and you are doing another case conventional orthognathic surgery, which has got more stability. Relapse is more in this case.
Distraction
Distraction of-
osteogenesis, sir,
Relapse.
because it will be controlled over a period of time.
Yes, and the amount of newborn formation, which is in distraction, basically there is more newborn formation. We're distracting the segment over there. There is less chances of relapse. And also in cases where there, like if there is BPI also there is present, there is soft tissue molding also, which takes place posteriorly in distraction. So distraction would be a better option treatment,
More stable.
more stable treatment.
Distraction.
Hmm.
Distraction has got more stability. Sure.
Yes, sir.
Yes. Relapse is more for conventional orthognathic surgery. Then what are the complications in Cleftcon surgery? Cleft surgery. What are the complications?
Related to distractions or related to
For both. First, you tell what are the complications of the distraction.
Distracted.
loosening
Loosening of
of the
hardware and
brain.
distractor failure.
And also depending
Patient
upon-
compliance.
patient compliance is one of the major thing, and also the periods of exact period of activation and the basically the latency and the activation period. If that is not taken into consideration rightly, if too early it happens, then there would be a fusion. And if it is not, if that latency period and the activation period protocol is not followed properly, sir. So
Also, if the consolidation is not complete, it could lead to failure. The bone formation will be poor. And soft tissue adaptation also we will not be able to predict with the distraction. So the period of distraction is also important. It is it occurs over a period of time. So it is a prolonged treatment.
Another important complication is that falling of the device. The falling of the device, especially for the external distractor. Any other complication?
Team one can
Uh,
answer if
A site infection, device site infection can be present if it is not maintained
Incomplete
properly.
structure, no damage can happen, or excessive bleeding during the intraoperative procedure.
Right. Then what are the complications of conventional orthognathic surgery?
Conventional ortho relapse is one of the major complication which is related. Then the surgical aspect, the stability which is present when the pain, infection, and bleeding, which are the common complications of any surgical modality. After which the splits, which the splits,
Osteotomy cuts.
osteotomy cuts, which are planned. So, keeping in mind the cleft and the bone deficiency in that in
Other
both
than this, what is
cases,
the major
the
complication?
So,
Other than this, what is the major complication?
The avascular
So-
necrosis can be
so-
there, especially
There was
soft
one
tissue.
cases. So, what precautions you would take to prevent this avascular necrosis?
So we have to be careful about our labial and palatal soft tissue flaps. They should not be overstretching of the flaps, and especially if we are going for multiple segmentization of the maxilla. If we can preserve the descending palatine artery, then that could be a beneficial for us. But if we couldn't, then it's fine. But the soft tissue had to be handled with care. Excessive stretching has to be avoided. That is one.
Should be minimally invasive, no?
Also, sir, adding to this, like coming to that one segment and two different segments, that is the SABG which we are planning, and the alveolar bone cleft, at what time it is operated. That is also a consideration in that, because
whether graft uptake has taken
graft
place on.
uptake is taken or not, because having a total one segment for osteotomy and three different segment where the stripping and mucosal elevation has to be done would also have a effect on the vascularity.
What are the surgeries for the management of vilopharyngeal insufficiency? VIP.
What are the
Procedures done for VPI correction.
Palatal
Palatal
lengthening
lengthening.
procedures.
Yeah,
what are the palatal lengthening procedures? That is what sir is asking.
Furlough, Z-plasty,
double Z-plasty, double opposing Z-plasty, furlough Z-plasty.
uh, pharyngeal flaps.
What are the different pharyngeal flaps?
Do not know.
We
Sir.
do not know this.
Other
Team one. Maria,
No, sir. No, sir. We do not know the name of the flaps.
sir, you can go ahead.
What are the post-operative? Then what about the stages of distraction?
Stages of distraction, latency, activation, and consolidation. So the stages of distraction differs from infant, children, and adolescents.
So first the osteotomy cuts are given. After that, the distractor placement is done, and the patient is kept in latency phase. Then activation and the distraction protocol is followed.
Latency period.
Activation is 1 mm per day.
In advance.
Latency period, how much?
5 to 7 days latency. 5 to 7. 5 to 7 days.
Okay. The next, what is the next? After
So, what is next, you are saying, sir? Activation
Activation
period.
is 1 mm per day. It
What
can
is
be 0.5 to 1 mm per day.
That is a rhythm. What is
Yes.
the rhythm?
What is the rhythm?
Define rhythm. In distraction, there's a term we use, rhythm. What is rhythm?
Uh,
Team one.
Team one, if you can answer.
No.
Russia. Maria.
So I think it refers to the frequency of distraction, the distraction which we do. That is a rhythm.
Yes.
Then what is the amount of distraction per day?
What is the
Amount of distraction per day. 1 mm per day, sir.
Yeah. Then how you frequently, what is the frequency of this?
So
Four
twice,
it can be
Twice
twice
or
or 4
four
times
times
in a day.
1 mm, 0.5 mm in the morning and 5 in the
0.5.
0.5 in the morning and 0.5 in the evening.
And what is the consolidation period?
Yes, 14 weeks. At least 2 weeks.
So 8 to 12 days.
12
2 weeks, sorry, 2
2
weeks.
weeks.
No.
Team one.
Yeah.
Team one, if you could answer, okay, what is the consolidation period after distraction?
6 months. 6 months.
No.
6 months.
2 to 3 months. That is the consolidation period. Suppose the patient wants to remove it earlier, what you will do? Suppose patient is not able to wait for 3 months, patient wants to remove it after 1.5 months or 1 month. Because of some wedding or something, patient wants to remove it earlier, what you will do?
Team one.
Sorry,
Can you
could we
please
not
repeat
hear,
your
sir.
question?
Pardon?
So can you please
Sir,
repeat
Please
your question?
repeat your question.
question?
Question, if the patient wants to remove the distractor earlier, I already told the consultation period is 2 to 3 months. If the patient wants to remove it a little earlier because of some urgency of marriage or some other things, they want to at the end of 1 month or 1.5 months, patient wants to get it removed.
What is the option with you?
What is
Sir
the option?
asks the same.
What is the option if the patient wants to remove the distractor?
Wants to get it removed before consolidation is full, complete. How will you proceed?
Activation is complete. Now it is in consolidation phase. So now the patient wants to remove it because of some reason. So do you have any option?
How will you retain the distraction is what sir asked.
Yeah.
Yes.
Extraoral part is the extraoral portion of the distractor can be cut.
I'm talking about internal distractor. Internal distractor.
Internal
Team one can team one answer?
distractor.
Team one. Maria Rafsha. Anyone among them? Then Dr. Avishkar or Umar sir can go ahead with the answer.
You can remove the internal distractor. At that time, you can fix it with the bone plates. That will prevent the relapse. The disadvantage of earlier removal is the relapse. That can be prevented by fixing a place in the osteotomy site. That will prevent the relapse.
Dr.
If
Avishkar, you want to ask something?
yes sir. Actually, if I have to add a bit to this, the retention of distraction, if you have to remove a rigid external distraction before the consolidation time, you can always use a face mask. A face mask is an orthopedic appliance which looks similar to a rigid external distraction. So at least the patient can wear it during the night or whenever he can for the sake of retention. In case of a anterior maxillary distraction, if for whatever reason, if you have to remove the distractor earlier, you can always go for retentive prosthetics because you will open up a space, right? You will open up an interdental space. So you can always give a dental bridge in that region.
Space maintainer can be given. Space maintainer.
Yes, a space maintainer kind of a prosthesis can be given.
Or
Uh,
intramedullary fixation also.
yes, yes, sir.
Interman.
Uh, correct. With respect to this particular patient that you guys have presented with a reverse overjet of 4 millimeters, what is your plan? How will you treat this patient? Which surgery will you opt for?
I couldn't get the question. Once more.
Sir,
Sir, the
for
question is for the PGs.
Sir, the question is for the PGs, sir.
PGs,
All
sir.
right.
yes, sir. So, sir, first of all, we would like to first know about the VPI status of this patient. So, depending on that, if the VPI is not present, like mild,
It is mild, yes.
present or
Already
borderline,
mentioned that it is mild.
then we would like to go for a leaflet one osteotomy for this case. Since the
Leaflet one osteotomy and advancement.
Okay. A palatal lengthening procedure can correct VPI till what millimeters? Till what millimeters can you actually correct a broken down VPI?
then what millimeter broken down, sir? What?
VPN connection, palatal lengthening, second line.
The most recent article suggests that you have to go for anterior maxillary distraction when the quantum of motion is more than 6 millimeters.
Yeah, right.
So till 6 millimeters, you can do a Lafort one even if there is a VPI present.
So,
So even if the patient has mild VPI and the nevus overjet is still 6 millimeters, will you still go for a Lafort one or will you still go for AMD?
Leaflet one.
Sir, because a recent study is being published in which they have compared distraction osteogenesis and outcome of V41 osteotomy, in which they have considered VPI also as one of the parameters. And the results of that study suggestive of there is no difference in mild cases if we go for a distraction osteotomy or a leaflet distraction distraction, anterior maxillary distraction and leaflet one osteotomy. But the previous year's studies which are there, they have shown that there's a significant difference if the VPI is present, and we should not go ahead with a leaflet one osteotomy, and we should do a AMD instead of a conventional leaflet surgery.
And say suppose this particular patient refuses surgery altogether. He has a negative overjet of just 4 millimeters. Does not want any more surgeries. 5-6 already हो गए. Do you have an accessory treatment plan? The patient has not come to the orthodontist, the patient has come to you as an oral surgeon. You have to treat him. He doesn't want any more surgeries. Negative overjet of only 4 millimeters.
Maybe orthodontic appliances.
By doing what? And then how will you manage the base of the nose? How will you manage the paranasal areas? How will you manage the malar prominences?
For the palate, we can do a rapid maxillary expansion. The
Team one, if you
Growth
could.
phase is already completed, so otherwise we could have gone in for the reverse full headgear, the face mask. But the growth phase is already completed in this
Correct.
patient.
Correct. So
Science has
orthodontically
been
only, how will you,
Uh,
any ideas, how will you manage orthodontically?
bone anchored maxillary protraction, bone anchored
um,
bone anchored maxillary protraction.
For an adult patient. So you can always go. Am I allowed to give out answers or?
The team one, if they can answer, otherwise we
Okay.
can.
If team one can answer.
You can go and give the answer.
You can
Yeah.
answer out.
Yes.
Okay. So you can always get rid of the third molars. You can always use buccal shelf screws and you can do en masse mandibular distalization because it is only 4 millimeters. I would not advise this for a 7 millimeter or a 6 millimeter or a 8 millimeter. It is just 4 millimeters. So you can get a positive overjet irrespective of that. with certain orthodontic appliances like Damon braces, you can get some amount of expansion also in the maxilla. So the crossbite can be the posterior crossbite can be very well corrected. Anterior crossbite you will correct by the mandibular distalization. The flatness in the paranasal region and the malar prominences you can always correct using fat grafts or silicone implants. And the rhinoplasties, you guys are better judges of how to deal with the nose. Okay, this is only with respect to a 4 mm negative overhead. So these are my 2 cents about this patient.
With the orthodontic appliance, you can correct it.
Yes, sir.
There are different appliances like Marpe, then
Correct, sir.
different things.
Marpe will also include some amount. Sarpe will include some amount of surgical, but sir, there are certain patients who refuse any intervention after these many surgeries. So there are options available as well.
Right.
Sir, if the question answers are over, I would like to invite Umar sir to present the final case with post-op photos.
Yes. One minute, we'll do it.
Charlotte, you can stop sharing your screen now.
Yes.
This is a levotone osteotomy. So I did a normal levotone cut, osteotomy cut, not a high levotone cut. Then it is fixed with the bone plates. This is after surgery. This is the result we got. This is before surgery. This the reverse overjet is corrected. Good profile. The reverse overjet is corrected. After the 6 months, this is the OPG X-ray. There is all. If anything, I will answer.
So now moving on, we'll move to our moderators if they would like to ask questions on alveolar bone grafting to team 1. So Professor Krishnamurthy sir, if you could.
Yeah, thank you, Tahir. I just have one single question to the person who presented alveolar bone grafting. What are the complications that you could get after doing the bone graft at the donor site, and what would you consider as a failure of bone grafting?
So there can be a dehiscence, the oronasal fistula can reopen, and the graft can come out. That would be a failure of the.
Maria, be loud.
Sorry, ma'am. Sorry, ma'am. So at the side, so I'm sorry, sir. Were you asking at the donor site or at
No,
the
no,
recipient
at the
site?
recipient site where you've grafted. Yeah.
Okay. So at the recipient side, the oronasal fistula can reopen. There can be a dehiscence, and the graft can come out if we have not closed it properly. Or if it has been closed, there can be some residual defect which can lead to gingival recession and periapic redness erythema around the teeth involved.
A corollary to this is after you have done the bone graft, the canine which was about to erupt into the graft does not come in within 3 to 6 months. What are your options? The graft appears to be intact, but the tooth has not come into the grafted site. What are your options?
So we can help. We can take help of orthodontics, and we can pull the tooth down with the help of the ligature wires or e-chain, I mean the gold chain.
How do you get there?
So if it's in a favorable position, if it helps, we can pull it out with the help of forces.
With the help of?
So for a ligature wire or a gold
Right.
chain.
Orthodontically, you mean? Yeah. Okay. Right. Thank you.
Sir, would you like to ask any questions on cleft maxillary hypoplasia to team?
Yeah, I will ask this question that the orthodontist was asking you. I didn't hear an answer from them. So if this patient says that he doesn't want any further surgery, what would you do? Can I ask that same question to the team? What would be we heard the orthodontist option of what can be done if patient refuses surgery. You as a surgeon, what decision you might take if the patient says, I don't want any more surgeries?
Nasal correction with rhinoplasty procedure and
No, so he said he doesn't want any surgery, right? So that was the point that was asked. So whether you do rhinoplasty or you do fat grafting or you do osteotomy, it's all surgery, right? If I as a patient say, sorry, no more surgeries, what option? What will you? He gave his option. How would you handle this case if he says no more surgery? Sorry.
Sir, as Sir mentioned that about the distalization. Sir mentioned about the distalization which can be done if the third molar.
So your answer is the same as what he said?
We do not know, sir.
Yeah, sir,
We could not answer.
answer that question. So
But this could happen to you, right? There could be a patient who comes in, then you say this is what you need to do, and he says, sorry, I don't want any more surgeries. You cannot say we don't have any answer, right? You have to tell him something. I am the patient sitting in front of you. What are you going to tell me? Okay, I'll let you think about it. I'll ask you one more question. We talked so much about the VPI, mild VPI, etc. Would you consider treating this VPI before you do orthognathic surgery in a situation like this?
If it is a moderate or severe case, we can go in for the VPI correction.
VPI correction first, and then wait and watch for at least more than 6 months to a year, and then going about for the orthognathic surgery.
And if it's a mild VPI, you wouldn't consider that surgery first. What is the reason for this?
Sir, because the
VPI can be worsened if we attempt, because there'll be already some scarring because of the previous surgeries.
Right.
So if we directly go in for the orthognathic surgery and it is a moderate or a severe VPI case, it could worsen the VPI.
Okay.
So that is why
but you can always operate on that post-orthognathic surgery, right? Can you not do that? So you had a VPI to start off with, you decided to do an orthognathic surgery. It stayed the same or it worsened. You could still operate it post-operatively, right? As a correction of VPI.
Sir, we did not get your question.
So you said that if there is moderate or severe VPI, you would correct that first. If it is mild VPI, you will go and do orthognathic surgery, correct?
Yeah.
My
Yes.
question is why are you discriminating between the two? Why would you not correct the mild VPI and why would you correct moderate VPI before you do orthognathic? What is the reason behind that?
So for in mild VPI also, the how much amount of speech or the speech, the hypernasality which is present in the voice, we'll consider those factors first and then go in about the surgery. It's not like if there is a mild VPI, we'll directly opt for the surgical procedure because any surgical intervention can worsen this VPI
Right.
to great extent. That is why.
Okay, let's put it this way. When would you do correction of the speech or the VPI correction before you do orthognathic in this kind of a situation where the assessment is that it's mild VPI? What would make you do that first?
If there is a risk to the airway, if it is if the soft palate means the position of the soft palate, basically if it is too posteriorly and it interferes with the glottis, we can go in for the VPI correction prior to the orthognathic surgery.
Right. Okay. Thank you.
So, sir, should we move on?
Yeah. Thanks.
Yeah, thank you so much, sir. I would like to invite Dr. Bhattacharya, sir, to ask questions. Sir, if you could ask questions about ABG to the team one.
Well, team one, when they presented, and I have little objection about, she said, slight malalignment of 1 median. It is almost 2 to 3 millimeter. Even half a millimeter 1 median disparity is seen from a distance. So be very careful. Now, you said it is an oronasal fistula. And then you have to do alveolar bone graft. So, how will you proceed? Which one will you do first?
So first of all, we'll close the oronasal fistula.
Right.
Then we'll go with the grafting.
So how will you close the oronasal fistula?
So we'll use the flaps, local flap, and then we'll suture it back.
What I want to emphasize is fistula means communication between two cavities. It is not sinus.
Yes,
There's
sir.
a difference. Okay. And if you just hinge a flap and from the top and try to close it, then between that and the alveolus, there will be a tract remaining. And that remaining tract will cause tremendous problem with the bone graft.
Okay.
You got my point? So that's why I'm asking, because you need absolutely watertight closure for bone graft. Therefore, prior to bone grafting, you have to do a closure, excision of the tract and closure of the from the nasal side. So how will you do that? How will you close the nasal floor along with the tract? Is it essential or not?
Yes, sir, it is essential. We have to do that.
And that is one of the most difficult part.
Yes, sir.
Okay. Then when you are doing this in this particular case which you showed, which requires a secondary lip correction also,
Yes, sir.
can you do the secondary lip repair and bone grafting simultaneously? That will avoid surgery, another surgery.
Yes, sir, we can do that.
You can do that. Should you do that or not? Will it hamper with the...
So I think I'll wait for the bone graft to take up and then the face, and then we can go for the lip later, not at the same time.
Because that will add another surgery,
Yes, sir.
which may be unnecessary. You are opening up the lip, everything is in front of you, the alveolus is also in front of you, and you can maneuver certain flap to have a watertight closure. So why not to take advantage of that? Suppose there is no lip problem, only alveolar bone graft. How do you assess how much bone to put and how much flap is available to accommodate it? This is a practical question.
So we can take the help of radiographic investigation. In this case,
No,
we can go for
on the table, you have done everything. On the table, you have to put adequate bone graft and you have to have a closure, watertight.
Okay.
And many times, it's very difficult to have a watertight closure with adequate bone graft. So what other tissue you can bring in? Have you heard of mucomuscular flap from the upper lip?
Sir, other team also can answer.
Yeah, okay.
Second team.
Second team?
So labiomyomucosal finger flap can be taken.
How is it taken?
Submu.
Where
Yeah,
from you
yeah.
take? What is the incision you make and how do you take it?
Labial mucosa region.
How much muscle incorporation sort of ensures the blood supply? Which muscle you incorporate?
orbicularis or
Orbicularis.
Yes. So which part of orbicularis oris? You also mentioned about cancellous bone from tibia can be taken. Okay. So how do you take cancellous bone from tibia? Because you don't need too much of tissue. You can take. So what is the maneuver you do?
So we can use a burr hole drill. We can use a drill for that.
No. Team 2?
Osteotome, sir, we can use.
No. Where from
How do
you?
you
Where
approach?
from you? Which site you take the graft? Which site of tibia? What is the landmark?
Proximal part.
Proximal
After-
part, there's no definition like proximal part. It's upper third, middle third, lower third. I'm asking you the bony landmark.
Upper third.
Upper third is a big area. Bony landmark. Bony landmark is tibial tuberosity. You make an incision, raise a flap of osteocutaneous flap or the osseous periosteal flap, and then push your scoop inside, and as much as possible you can easily scoop out from that small area and put them on your tray and you use it and just close it. In fact, that is an easier procedure than all the discussion went on iliac crest for this small requirement for alveolar defect. Okay. Even for larger defect, you can have adequate. So it's your choice, of course. And the second presentation, there was, you said that there is increased mandibular growth. Is there increased mandibular growth or we are talking of maxillary hypoplasia?
So it was maxillary hypoplasia, but
Why did you say increased mandibular growth?
It was compensate, means it appeared to be like the mandible was
It appeared
forward.
because the maxillary
Maxillary
hypoplastic.
was hypoplastic.
So you should not mention there is increased mandibular growth until you prove it
Yes, sir.
by radio diagnosis. And this second patient, certainly you must mention that it requires a rhinoplasty. Even after orthodontic treatment, if you see the profile, lateral profile, you will see the nasal part has become little worse than what it was.
Yes.
Although the rest of the part was absolutely fine.
And
So if you see the basal bridge, there is it has become more pronounced. Okay.
2 mm.
So therefore, the thing is that because the patient wants full recovery, full aesthetic and functional result, therefore, this patient will require an open rhinoplasty, not close.
Yeah, patient, we are planning for that.
Yeah. Thank you.
Thank you. Thank you.
Thank you so much, sir.
Thank you, sir.
I would request Dr. A.K. Chaudhary, sir, if he could ask a few questions, if he is around.
I think sir is not there.
So, sir, should we move on to the judges then for questions?
Yeah, yeah.
So, Mustafa Kader sir, if he can ask questions.
Let us open it for all the judges. Anyone among them can put his comments or questions.
Hello, good evening all. Can I ask a question?
Yes,
Yeah,
madam.
yeah,
Please.
yeah.
Yes.
Yeah, this is for the alveolar bone grafting. I would just like to know, after bone grafting, after how many days or months would you like to go for an orthodontic treatment if required?
We'll wait for at least 3 months.
3 months. Okay.
Anybody among judges again?
Or if Dr. Nitin Mokal sir would like to ask anything on alveolar bone grafting or
Yes, there is a phone
Yes,
call.
sir.
There is a phone call coming. Hello. Hello.
Mustafa Kader sir is there? Then
Just I want to clarify one thing. Can I ask?
yeah.
Yeah. When Madam Charanya Madam was talking about that fish membrane, somebody talked about that, na, some collagen. What about putting there the dermal matrix? There are reports, people are putting dermal matrices for the fistulas, if there is tight lining and all that. There are reports, literature is there. What about can we use, Dr. Adil can take it, can we use over the graft any dermal matrices if you have some problem with the watertight closure so that you can put it and you can augment it with the lining? Any experience? Or
Yeah, so regarding that fish also, which they said that fish is also collagen. It's just a different source of the collagen. So at the end of the day, it's a collagen matrix. So none of these derivatives we can expect to work if there's a opening. It cannot be used to replace the mucosa. So if it's an additional layer, well and good. It's used more as a barrier so that the soft tissue cells don't migrate inside. So any barrier would work fine. Any resorbable barrier would work fine.
that was my point, because when we use for the palate, so there is no graft there. So you can close it with, you can augment it with a part of the lining there, and you can put the dermal matrices, whatever is available this time in the market, whatever. So can we use it here when we are putting a graft so that the watertight closure is maintained? Or at the time being, we can't?
No, below the closure, it can be used. It can't be used if we are not able to achieve watertight closure. Below the closure only it can be used.
It can be used for augmentation. Then over that you mean to say that we have to put the lining, right, sir?
We have to. We have to.
Yeah. Thank you.
Thank you.
Thank you. Then we can go with the additional cases by our panelists. Ji Tahir.
You want me to start?
invite one after another, Umar.
Yes. Altaf sir is there?
Yes, I'm here. Can
Yes,
you hear
sir.
me?
Yes, sir. Good evening,
Hi.
sir. Good evening.
Good evening, Umar. All well?
All fine, sir. Pleasure.
You want me to go ahead?
Yes, sir. Please.
You can share your
Can I-
cases.
Yeah, I'm screen sharing. Are we able to see it?
Yes, sir. You can make it full screen, sir.
Yeah, good. Yeah, can I go ahead?
Yes, sir, please.
Yeah. Okay, this is a young girl, had lip and I mean, this is obviously just to summarize things, and it's just to bring out the best foot forward of the candidates. So
Sir,
8
it is
years old.
open for both the teams. They can answer.
In turns, I think the ABG person gets the first question, and the other
Okay.
team, if she cannot answer, and you can switch anytime, madam. So 8 years old, lip and palate repaired in infancy, speech is good, mid face is acceptable. Does she need any further intervention at this stage? Go ahead, please.
That team 1 comes, then team 2 can.
So I can see some occlusal canting.
No, but my question was simple. Does she need and did you hear me right? She's 8 years old, lip and palate operated.
So no, she does not need any further treatment as of now.
She does not need. What about the other team? We
She
spoke a
has
whole
been
lot about.
grafting.
Pardon me?
If there is, we did not ask whether she is having any alveolar cleft which is present or not at this particular stage.
Do you if it's lip and palate, which it's a cleft of the lip and palate, do you or do you not expect alveolar cleft?
Alveolar bone grafting should be done.
So she needs a alveolar bone grafting. Okay. Okay. If so, what other information? I mean, what will you do next? You'll need a little more information. I just want basic. Don't look for catches. Don't look for some kind of secret stuff. Just basic stuff. You're seeing her now, full face. You decided. Team 2 decided. Team 1 did not want to do anything. Team 2 decided that they wanted to do alveolar bone grafting. And now, what do you want to know? I mean, is there anything else you want to know? See, no,
The
very basic.
radiographic examination to know the size
Before
of the
that, you like to see the patient's teeth.
Yeah, so
the the clinical examination.
I think the question should go back to team 1. Would you like to?
So we'll go for a intraoral examination.
Intraoral examination. Okay, there you are. That's how she is. I mean, can you describe that?
Yes, sir. So the central incisor of the first quadrant, it's rotated, and the arch has collapsed on that side. But I cannot see any oronasal fistula in these clinical pictures.
Why do you want to see nasal fistula? If it's well repaired, you should not see one, yeah?
Yes, sir.
Yeah. So there is a collapse of the lesser segment. Is that expected or not expected in a unilateral cleft?
Yes, sir.
Okay, so you have one, and you have a. Why did that incisor rotate? And there is one incisor missing as well, isn't it?
Yes, sir. Lateral incisor is missing.
Yeah. So why did it rotate?
Because of the clefting.
Lack of support, yeah, in the bone. Okay. Now, what do you want to do next? Oh, sorry. Okay. Do you need any other? Do you need some investigations now? You decided on it. You looked at her teeth and said there is a problem. Do you need any investigations now?
The radiographic investigations would go for.
Okay, there you are. So what do you see? Only the salient points.
There's impacted 313, I can see.
So what is the primary? I mean, see, there are many reasons for you to do alveolar bone grafting. I think Somebody already discussed it. So you need to complete the arch. You need to have a platform for the canine to erupt, isn't it?
Yes, sir.
Yes or no?
Yes.
Yes, sir. Yes, sir.
Okay, excellent. Now, what's happening to the canine? Would you like to do it just before the canine erupts, or would you like to do it at your convenience, or wait for the canine to erupt?
No, so we do it before the canine erupts, before the root is
So
at least one
at what stage of eruption, I mean, development of canine would you like to do? The
So
permanent canine.
either the root of the canine is half formed or it's 2/3 formed, then we can go ahead
Okay.
with grafting.
So what's happening with it here?
It's more than that. I can see it's almost at completion. Only
Okay, it's
one-
ready to come out.
Yeah.
Okay, so you need to do it quickly. So is there anything you saw the arch form, you saw the thing? Is there anything, and you decided to go ahead and do a ABG? Is there anything else you can do to make things easier for yourself
We can expand the
and the
arch a
patient?
bit. Actually, yeah.
Okay, so you want orthodontic intervention.
Yes, sir.
So this is what happened. Yeah.
Yes,
Now
sir.
you're ready to go and graft. It's a yeah.
Yes.
So what would be I mean what would be your comfort level of the alveolar gap for a good bone graft?
I'm sorry, sir. Can you repeat? I did not understand.
What would be the alveolar? I mean, when you want to bridge the alveolar gap, isn't it? You need to create a watertight compartment so that you can fill it with bone and stuff. So what would be your comfort? See, you have an option here of getting an optimal width of the alveolar cleft. So what would be your, I mean, it varies, but what would be good for you? Can team 2 try? You want it very close. You don't want it very close. You don't want it very wide, don't you? I mean, the alveolar cleft should be not be too wide, nor it's not too tight. Both give you trouble, yeah? And ideally, the both the segments should be aligned as well. Yes. So, what is the width you're looking for? If you have if you have a choice of choosing a width.
Something between 3 mm to
Pardon
10
me?
3 mm to 10 mm.
God, you are a very brave surgeon, isn't it? You don't. I mean, you have a very wide range. I would choose if I mean, of course, sometimes you have to do with those things when you don't have a choice. But I
Not
would
a
choose
choice,
somewhere in
not a
about
choice,
5
like,
millimeters.
looking at this, if the defect doesn't appear to be too small, that less than a 3
That's
mm,
what we want to know. So I think we got a sweet spot there, about 4 millimeters, 4 to 5 millimeters, which is quite good for us. And then this is what we did. Yeah. So now you have a question. I have a question for you. I have a question for team 1. So you already said you will swing the lateral segment. Yeah. When you make your cuts, would you give advantage to see before you do this, you have this alveolar cleft. Yeah. So would you give advantage to the oral side or to the palatal mucoperiosteum or to the buccal mucoperiosteum? When you place your incisions, initial incisions to separate the continuity of the oral and palatal mucoperiosteum.
The buccal side advancement would give us better results.
You would give advantage to the buccal side.
Yes, sir.
Well, team 2 has any other thoughts?
Buccal side.
See, buccal side you can advance. I mean, you yourself said you can score the mucoperiosteum. You can make back cuts and swing it medially. Yeah. Whereas palatal side you have limited tissue, so you need to have 3 surfaces, isn't it? Like a prism. You need to reconstruct the palatal side. In this case, it may not be that that critical, but you need to make a hinge flap to close the palatal mucoperiosteum. The palatal side, you don't have any other tissue other than the one you're going to make a swing from as a hinge flap, yeah? Whereas nasal, anyway, you don't have a control. You need to go there and separate it and close it. Oral side, you have the advantage of swinging from the lateral from the lateral element. You can make a back cut and you can also score the periosteum. So the advantage should be to the palatal side. Okay, now there you are. So you also discussed so this is after the bone graft. You can see the thing, and you can see that the canine has started erupting. Yeah.
Yes.
So that's what we did in this child, and so this is just a summary of the thing which I think is already fully discussed. So we'll go ahead with. I have some more questions for you. I'm just going to go to that. Madam, can I continue?
Yes, sir.
Yes,
You can
sir.
continue.
Yes, sir. Yes,
Okay.
sir.
Okay. So now the team 2 gets the first question. I mean the first opportunity to answer, and so this is this is a 17-year-old girl.
It is not shared yet.
Pardon me? Oh,
Not
it's not
shared
shared.
yet.
I'm sorry. I'm sorry. Yeah. I'm a little bit lost. Sorry about that. 1 minute.
Must be some other PPT, sir.
No, it's another PPT. It's in front of me. Just going to close it. Yeah. Okay. Okay. I think I will figure out what to do. Have I won?
Yes, sir.
Yeah, yeah.
Okay.
Full screen.
Yes, sir.
Yeah, I'm doing that. My computer seems to have a life of its own. Are we good now?
Yes, sir.
Okay. 17-year-old girl, cleft of the primary and secondary palate again, lip repair at 5 months, palate repair at 18 months, re-repaired at 6 years. She had an ABG at 8 years. Now, she wants to look better. Can you identify what is her problem? Team 2, please.
So she has a retruded maxilla. Other than that, bilateral paranasal hollowing can be seen. Even the nose appears, the tip of the nose and the columella is deviated to left. The nose appears to be deviated to the right. There is an anterior open bite, and it appears to be a bilateral posterior cross bite. In the occlusion photograph.
Puckering which is present over her Pogonion region, which is suggestive of that tension over the muscles over that. Obviously, hyperactive mentalis muscle activity over that region.
Positive lip step is present.
Okay. Okay. Now we'll concentrate on the bone. I mean, on the skeleton. You more or less summarized, but I wouldn't agree with the paranasal hollows. The entire platform, the entire midface is behind. Actually, the nose is sitting in a well. It's not the nose is normal. From when you describe it as paranasal hollowing, you're suggesting that the nose is all right, except on the both sides there is a problem. Actually, the entire mid-face is a problem, isn't it? There's no platform for the nose. It's what should, I mean, it is posterior, I mean, behind what should be normally there. Okay, now, so I've summarized it. It's a concave profile, class 3 malocclusion, reverse overjet, anterior open bite, occlusal cant, and what management plan for this? Let's start with let me take it step by step. Would you choose? I mean, if you had to choose between distraction and orthognathic, what did you choose in this case?
What is the VPI status
of this patient?
Well, that is see, her speech was all right, but the thing is, it wouldn't matter for now, because if you at this stage, if you went and corrected the VPI and then tried to, it's like putting your shoes first and then trying to wear the socks. If you have to move the maxilla, you have to move the maxilla. Wait, I mean, the critical part comes when it's very early and the speech is developing. Now you have a 17-year-old girl. How does it matter how her speech is? In her case, the speech was all right. And the discrepancy is not very huge. We'll come to the discrepancy. So advancing the maxilla is not going to change anything. And even if it were severe VPI or whatever VPD, I would wait to correct the mid-face before I tackle VPD. I think it's the logical thing to do, isn't it? Okay, now management plan. So
what is the amount of
you didn't answer my question. You hedged it. Distraction or orthognathic surgery?
Orthognathic surgery.
Orthognathic surgery.
Okay, why?
Because along with the retruded maxilla, there also appears to be a cant and an anterior open bite. So we may want to do
Basically, if you have to
rotation.
choose between distraction and orthognathic surgery, would you choose orthognathic surgery in a growing child?
Completion of growth is 17 years.
Yes. So in this girl has completed her growth at 17 years. She looks like she has completed her growth. Yeah. So
Yes,
you can now opt for orthognathic surgery. Yeah. And the moment, and like you described, there are a few problems which probably better with orthognathic surgery. Okay. So what would be your plan? You should you will do some orthodontic stuff first. Yes, no.
Orthodontic stuff, decompensation, because the compensation which has happened because of the
No, will you do
retruded,
orthodontics or not?
Yes, we
Yes.
would like.
What will you do?
We want to correct the reverse overjet if possible. How
You
much?
will correct the reverse overjet with orthodontics.
The anterior open bite
The
which
anterior-
is present, we need to correct the anterior open bite, and then the posterior cross bites also.
Is this a good option? I mean, is this a good candidate for surgery first?
So also whether there is constriction of the maxillary arch. Surgery.
You saw that there was no constriction.
So no.
There is always a apparent constriction because as the max, if you are advancing the maxilla, as it comes forward, it corrects itself. It is a relative relative discrepancy between the maxilla and the mandible. Yeah. No, orthodontics. So I'll tell you what you. I mean, surgical. What is your plan? Surgery wise.
Surgery wise, bijaw surgery for this patient.
Okay, so by jaw. What will you do with the maxilla? What will you do with the mandible?
Depending upon the reverse overjet.
I mean, I'll tell you the reverse overjet is about 4 millimeters.
So only Lefort one advancement and clockwise rotation of the maxilla probably.
Mhm.
So
But
can you
there's
please show
anterior
us the
open bite
clinical
there.
pictures once?
We want to look for the lower facial height. Whether
You
it
had a opportunity to look at the clinical pictures enough. So you want bi-jaw. Now
Yes.
are you changing your mind to single jaw? Can the question go to the other team, please?
Team
So we
one.
can go for single jaw surgery, early foot one.
How will that will that sort out the open bite? It was quite 2-3 millimeters there.
So we can take the help, with the help of orthodontics. We don't have to go for a bi-jaw.
Okay. Is it going to take some time to do that
Yes, sir.
with orthodontics?
Yes, sir, it will take time.
Will you do anything post-op?
Post-operatively, we can attempt that. Closing that.
Okay, okay. There are many ways of skinning a cat, so to say. So this is what we did. So we had fixed orthodontic appliance for leveling and aligning the maxillary mandibular arches, left foot one osteotomy for advancement, subapical osteotomy to upright the lower incisors, and settling and reverse pull headgear for 6 months for retention, because there is a very, I mean, in cleft particularly, there's a high, so that's what we did. Segment A, ignore the lines for the BSSO. It's only the up, I mean, segment A advanced and segment B used to upright the lowers. So that's her pre and post-op. And so that was what is corrected. Advancement of about 6 millimeters. Cant correction. Somebody did notice the cant. It was impacted on 3 millimeters on the left hand side, and subapical osteotomy and set back to the width of the first premolar, which was extracted. That is a pre and post. And that's a pre, immediate post, 1 year and 4 years down the line. Okay. So this is another girl. With this we'll be very brief. I mean, I think we have taken a lot of time. Now, this girl, much little bit younger. I think she was 14. So what do you notice? Can you describe? This is team 2. Describe her in terms of mid-face and dentition.
So the profile appears to be concave with the slight anterior divergence. There is increased vermilion show with the lower lip short, upper lip length. Nose, the columella and the nasal tip appear to be deviated to the left, with left alar base flaring, retruded maxilla is present. Also, she appears to have a mixed dentition in the occlusion photographs.
It's not, she's not in mixed dentition. I mean, there might be 1 or 2 retained deciduous, but she's.
Her middle third of the face appears to be more longer compared to the upper third and the lower third facial height.
I mean, that is obvious. You said mid-face hyperplasia, isn't it? Is there anything else that's obvious about the teeth?
Crowding and the narrow.
Yes, there's crowding. Why is there crowding? Do you expect crowding in cleft cases?
Yes, the arch is constricted, so because of the collapse.
Is it constricted? Yes, constricted. But is it the arch itself is smaller in the cleft because it's not it's not grown to its normal potential. It's not posteriorly placed generally, yeah. Though we use, we cheat a little bit by advancing it many times. But the problem with the cleft is it's a smaller arch, yeah. Would you, team 2? Team
Yes.
1.
Yes.
Agree or not agree?
Yes, sir.
Yes, no, maybe?
Team 1.
I can't hear what team 1 is saying.
Yes, sir. You're right.
Okay, so what should you do if it's a smaller arch, which is obvious by the crowding there, and there is also a retrusion? Is there something you can do to correct all this? Can team 2 answer that?
So palatal expansion can be done.
Can be done for this patient.
So you'll do a palatal expansion,
But
and
years,
which way will you expand the palate? Transversely or anterior-posteriorly?
transfers.
And I mean, well, you can see there is no major crossbite. The upper and lower are almost the same width.
Which there was full headgear.
And this discrepancy is about 5 to 6 millimeters. You think reverse pull headgear is going to do any good? See, we have a problem here: a small maxilla, crowded teeth, reverse overjet, hypoplastic midface. We need to correct all this.
You can go
in
for
the
Both,
discussion.
it's
growth
open to both the
phase.
teams.
She's in the
Pardon
growth
me?
phase, so we can try the appliances.
You think she'll grow much more? She's 14 years.
Just
So it's
She may grow a
almost
little
for
bit,
the
but
female growth,
it's
the
almost getting post-pubertal growth.
post-pubertal growth phase till at least 16 years of age.
okay, I concede that. So anything else you can do? I mean, so you don't want to do orthognathic surgery at this stage, obviously. So anything else? BAMP, with this kind of thing, BAMP is something which is, again, 3-4 millimeters. I would agree this is a little bit more. And nearing, I mean, that would be better off. BAMP would be much better off when the child is 11, 12 years. Now the child is 14. No, anybody answer? I mean, nobody can think of anything which will solve all these problems. Okay, I'll show you what we did. AMD is what you need to do. It increases the size of the maxillary arch, allows for aligning of the teeth without extraction, preserves masticatory surfaces, because when you do maxillary advancement or even setback of the mandible, you're actually reducing the masticatory surfaces, and it can be used as an interim measure before growth is complete. And particularly when they're growing, they need to they want to present a nice face to the world, and it's a stressful period. So this is a good intervention at this time. So that's what we did. That's the segment that we want to do. And so that is her that's the distraction, and that is the lower two panels are pre and post. And that is is pre-post on the left-hand side. On the right-hand side is her occlusion. Yeah. Any thoughts on this? Any you want to make any comments on this? You had any other plan? Could have been better? No. Okay. And this is the algorithm which we published some time ago for cleft maxillary hypoplasia. It's there in the Dr. Karun Agarwal's Indian textbook of plastic surgery as well, in the chapter. And this is originally published in the Journal of Craniofacial Surgery. Thank you.
Thank you,
I'm
sir.
going to stop screen sharing.
Now we Tahar invite to Dr. Umar sir.
If Umar sir can, If Umar sir can present the final cases.
Yeah. 1 minute. This is a bilateral cleft lip and palate case. Patient has got hypoplastic maxilla. So we did a conventional lipot 1 advancement osteotomy for this patient.
Sir, your volume is very low, sir.
This is a bilateral cleft case.
Yes.
Bilateral cleft lip and palate. So in this case, after bone grafting and everything, I did the orthodontic surgery. The orthodontic surgery performed was lipot 1 advancement in the first stage. Then second stage, I did a rhinoplasty also. Yes. This is the result I got. I don't have the other photographs. If any questions if you want, you can ask.
Fine, sir. Only one case, or you want to share more cases, sir?
Yeah, only these 2 cases.
Sir, is this, sir, if I may ask, is this only maxillary advancement or have you performed a mandibular setback also?
Yeah, in this case, I did a maxillary advancement plus BSOSO setback also. The Bimax, Bijo surgery.
Yes, sir.
Okay, sir.
The rhinoplasty is also done later stage.
Thank you, sir.
Yeah. Thank you so much, sir. Sir, should we move on to Dr. Adil's presentation now?
Yes. Dr. Adil, you can share your screen.
Yeah, I think just one thing. We keep talking about half of the. My voice is audible, right?
Yeah.
Screen is visible. Okay. So just for the students' sake, we keep saying that half of the canine root should be formed, or 2/3, or 1/3, or whatever it is. But how do we know what's the full length of the root? We don't know that, right? So way to judge it is if the root size is same as the crown size, that is half of the root. If a root is partially formed and not the same size as the crown, that's 1/3. And if it's more than half, then we call it as 2/3. And from 1/3 of the root formation till 2/3 of the root formation, anytime you can do the alveolar bone grafting. So this is a case 2. I think Mahesh Prabhu sir had asked me during the first Plastiquest meeting that we had. So we had a case of a prominent protruding premaxilla, and case was about 6, 7, 8 years old. And nowadays, if this case comes to us, we always try to do NAM in the primary, and then to do a primary repair, try to avoid a premaxillary setback, or we do a lip addition and then do the final repair at the age of once the mixed dentition 5, 6 years old, final repair. But some cases we have got who are in this situation, and there's no chance of doing a bone graft or anything in the future. Orthodontically also not possible to get this segment back. These are the radiographs. So it's quite severe. This is the intraoperative this thing where we did a vomerine osteotomy and a spart resection. And we wait till the 7, 8 years age so that the growth is not that much affected. We don't do it at a younger age. And a segment of the vomer is resected. It's about 1 centimeter in size, and it's set back, and a long screw is kind of used to fix the premaxillary segment to the remaining vomer. And that's what we had on table. This is the occlusal post-operative radiograph and the lateral ceph pre and post-op. And this is the clinical photo afterwards. So sometimes it's also clubbed with the bone graft, but I think it's actually not possible to do that. I don't know how people do it. Basically, getting a closure over the vomer after putting the screw is important. And if you do the bone graft, you won't be able to do a closure of the bone graft properly. And also the vertical level, anteroposteriorly, we are able to take the premaxilla, set it back. But supero-inferiorly, still there is a mismatch. So that needs to be corrected orthodontically before we can do a bone graft. If the central segment and the lateral segment bone is not at the same level, the bone graft will not be successful. So they have to be orthodontically leveled. And that's not completely possible during the vomerine osteotomy by itself. So this is what she looked like, and psychologically also it becomes a big boost to the patient. Lots more work has to go into her, but this is midway. It's another case of a different situation where we've got too much of a gap between the segments, and we may not be able to get soft tissue to close over our bone graft. This patient had primary complaint of oronasal regurgitation. He was an adult patient. So we tried to do made a custom appliance of a tooth bone distractor. And we've done this with bone devices, bone distractors as well. And this is containing a jack screw, but we've also done it with Hyrax appliances. So we've done different situations at different times. A osteotomy was made between the premolar and the molar, and carrying on, that's the vertical cut very carefully with a piezo surgery unit, not harming the roots, and a horizontal osteotomy through the lateral wall of the maxilla, and as well as on the lateral wall of the nose. And once it's separated, we cement the distractor intraorally, and then the distraction starts. And in 8-9 days, you can see that the teeth have completely moved together. The distractor has completely closed, and the alveolar segments have come closer together. Then at one point, we remove the distractor, and you can see distal to the premolars, the bone is formed out there, the bone which is regenerated. And in the alveolar cleft, we did a conventional bone graft and closed the fistula. He refused orthodontics. He was coming to us from maybe 400-500 kilometers away, and he got a bridge in the posterior segment. And this is what we ended up with. So very rarely we'll need to use transport distraction or premaxillary setbacks to facilitate our bone grafts. I'm okay to take any questions if there are.
Yeah, thank you so much, sir. Are there any questions?
What about the Dr. Adil? What about the vascularity of the segment when you do the setback? So there is some worry always, and nowadays it is not now very favored one.
Yeah, even we don't prefer it. But the
Yeah.
vascularity, we have to make sure in this case it was very safe because we didn't raise only one central midline incision, and the blood supply is coming from the nasal side and the labial aspect. There are people who are doing primary bilateral cleft lip repairs and premaxillary setbacks when the child is 3 to 6 months. That's when vascularity becomes bigger problem. Only when absolutely necessary we are doing this procedure. Having all the considerations of growth and all that taken into our treatment plan.
Yeah. I have done one. It went on well, but only concern my preoperatively was also the same about the vascularity. But these patients, when they are grown up, they behave well, and there is a lot good outcome,
Yeah,
aesthetically better outcome.
I think in this, sir was asking me last time what kind of screw we have used. So we've used a kind of a lag screw. The threaded part is going into the vomerine bone, and the non-threaded part is going into the premaxilla. So it's like a light screw. It can be seen
Yeah.
in the occlusal radiograph.
Right. Right. Thank you, Dr. Adil. Thank you.
Thank you.
Dr. Charanya also has to showcase her cases.
No, sir, I don't have any.
Okay, ma'am. Thank you, ma'am. You don't have.
Thank
Dr. Avishkar Mokal, if he could tell us something more about the orthodontic part.
Yes, here. Avishkar.
Yes, sir, I'm here.
Okay.
Yeah.
Please go ahead.
Yeah.
Can enlighten us in a better way.
Yes, just a minute. Uh, do I have permission to share my screen?
Sure.
Yes, sir. Yes, sir. If Dr. Adil could stop sharing his screen, I think his laptop is.
I think it's done.
Yes, yes.
I'm going to be giving just a brief overlay about certain orthodontic considerations before secondary alveolar bone grafting. Am I audible?
Yeah,
Yes.
Okay.
You can start.
Yes, sir. Okay, so like we have already discussed in detail about when is the early secondary alveolar bone grafting done and when is the late secondary alveolar bone grafting done. Early is done at the age of 5 to 7 years, late at the age of 8 to 12 years. Early SABG generally depends upon the eruption of the lateral incisor, whereas for late SABG, we are dependent upon the eruption of the canine. Early SABG requires regular monitoring of the patient as the period of orthodontics is more. So you need to start orthodontics at an earlier phase and you need to monitor the patient a long time after the surgery has also been done. Whereas for late secondary alveolar bone grafting, the period of orthodontics is slightly less because you can combine the pre-surgical orthodontics along with the post-surgical orthodontics or the comprehensive orthodontics. Now let me just clear out these terms for you. What is interceptive and what is comprehensive orthodontics? So in our center, we generally prefer late secondary alveolar bone grafting. We combine it with comprehensive orthodontics also, and we take advantage of the bone growth and the remodeling at the pubertal age during late secondary alveolar bone grafting. So is pre-surgical orthodontics required in all cases? So depending upon the age, different types of orthodontics are required. One type of orthodontics that is required is called as interceptive orthodontics. Interceptive orthodontics technically means that you are seeing something going wrong in the patient's mouth and you are intercepting the problem. So you're not dealing with the entire malocclusion of the patient. You're just dealing with something that is going wrong at that particular moment. Maxillary arch expansion, as we all know, is pretty straightforward. I'll be talking about that more also. And comprehensive orthodontics is the full-fledged stage of orthodontics, which we carry on till the adulthood of the patient. This is one example of interceptive orthodontics where we see that the patient is developing into a class 3. The maxillary incisors are going in, mandibular incisors are coming out, and there is a lot of dental caries that is there. So at this particular stage, if we have to consider this patient for bone grafting, then we do uh, go ahead with some amount of restorative pediatric dentistry, and we do some amount of interceptive orthodontics, where we bond the patient and try to get him at least into an edge-to-edge arch or into a positive overjet, so that later we can guide the patient into a class 1 skeletal pattern. So this is how we started. This is where we were. Second type of orthodontics that we need to take before secondary alveolar bone grafting is maxillary arch expansion. Now, there's a lot of mix and match that can happen with maxillary arch expansion. The first type of expansion that we can achieve is with using braces. So there are no expanders used. You use conventional braces and you achieve a decent arch form. This can be done in borderline cases where there is no major physical crossbite. Okay, so you can avoid using an expander altogether and you can go ahead with using braces. Second kind of expansion is a slow expansion. So you use something like a quad helix, which is a wired expander. So slow expansion can be used in cases where you have a long time at your hand to attain maxillary arch expansion. You are waiting for the canines to develop, and you can create space slowly. So the advantage of slow expansion is that technically the appliance is very inexpensive, but the major disadvantage is you have to spend a lot of time and you have to monitor the patient quite a bit. The third type of expansion, and the most preferred by myself, is the rapid maxillary expansion, in which you can use Hyrax screws or you can use fan shape screws depending upon the requirement of the patient. So the way we do bone graftings using maxillary arch expansion in a rapid format is we go ahead with the maxillary arch expansion. Once the plate is locked, we give a consolidation period of 3 months. Obviously, we monitor the eruption of the canine at this particular point. So if I feel that the canine's root have developed enough after the 3 months of consolidation period, I remove the expander 2 days before the surgery, and then we go ahead with the bone grafting. Now, there can arise a situation where the patient has a major crossbite. You have to give a specific kind of an expander, but the basic dimension of the screw only won't be accommodated in the jaw, in the arch form. So in those situations, you have to go for braces first, expand the jaw as much as possible with the wire, and then go for a expander. So that will give you the optimum results as required. So after a secondary alveolar bone grafting is done, and like I said, we can most of the times combine it with comprehensive orthodontics. So the braces that I've put before the bone grafting are only continued after the surgery is done. And depending upon the type of patient, whether if he requires orthognathic surgery, then the orthodontics is moved towards pre-surgical phase. If the patient doesn't require any orthognathic surgery, then you can directly go ahead with comprehensive orthodontics. You can save some space for the teeth which are missing, and you can go ahead with prosthetic rehabilitation at the end. So these are the two major kind of orthodontic scenarios that you can get.
Okay, thank you so much, Dr. Avishkar.
I think it's stuck, but yeah, I was almost done any which way, so it's okay.
Is it left? If it's left, please complete the.
You have more slides or it is done?
Yeah, this was probably one of the last
Yes,
slides
yes,
that
please,
how do
please
you.
continue. I'm sorry, I thought the.
No, it's okay, Tahir. So this is the just the one of the scales that we generally use to assess the survival of the bone graft, which is called as the Berglund grading system. So we assess the amount of bone that is there on the entire level of the roots of the teeth that are present, and depending upon that, we decide whether it is a level 1, level 2, level 3, or a level 4. Anywhere between a level 3 is also considered to be a successful bone graft. So this is just the summary of the protocol that I just mentioned. Post bone grafting is done, we generally start orthodontics after 3 weeks. That is, we wait for 1 sigma of bone regeneration. If required, canine traction is started initially within a week of the surgery that is done. Active orthodontics is always done after 3 months of bone grafting. Yeah, that's my take on pre-surgical orthodontics for secondary alveolar bone graft.
Thank you, Dr. Avishkar.
Thank
I
you.
think
Thank
we
you,
have
sir.
achieved the stage of getting the feedback